Hello, everyone. My name is Shirley Kessel, and I have chronic migraine. And I also come from a long line of family with migraine and chronic migraine. I'm also the executive director of Miles for Migraine. And I want to welcome this evening all of you here to the Patient Town Hall program, Achieving Empowered Migraine Care and Living Your Best Life, a patient town hall for the LGBTQI plus community. This town hall is delivered in partnership with Miles for Migraine. This activity is provided by Prime Education through educational grant support from Pfizer. Our expert faculty leading today is Town Hall's Dr. Anna Pace, and our advocate is Joseph Coe. I will allow each of them to briefly introduce themselves. And Dr. Pace, would you like to go first?
Sure. My name is Dr. Anna Pace. My pronouns are she, her. I am a headache medicine specialist and assistant professor of neurology at Mount Sinai Hospital in New York City. I'm also the director of the Headache Medicine Fellowship there, as well as the director of the Transgender Headache Medicine Program.
Joe?
Hi, and I'm Joseph Coe. I work for the Global Healthy Living Foundation, which is a nonprofit aimed at helping people live healthier, happier lives. Also, the co-host with my colleague Sarah Shaw of the Talking Head Pain podcast. I'm a gay man who lives with migraine, and I'm really excited to be here today. My pronouns are he, him.
Okay, thank you, Dr. Pace and Joe.
Welcome, everyone. We're really excited to be here. Today, we're going to talk about a lot of different topics, but we'll first kind of cover a little bit about the impact of migraine specifically in your life, as well as in the LGBTQI plus community. We'll learn how to overcome stigma and seek appropriate care. We'll talk about how to make plans for tracking your symptoms and selecting migraine treatments. We'll also discover ways to communicate effectively and become an active participant in your migraine care. But most importantly, we'd love for this to be an opportunity for everyone to share your experiences and ask any questions that you may have. Okay, so what is migraine and how does migraine impact the LGBTQI plus community? So what is migraine? We think as providers of migraine as more than just a headache. It's really a chronic neurologic condition that involves not just head pain, but so many other symptoms. And it clearly is very, very prevalent, especially in the United States. Over 4 million people in the United States actually are affected by migraine. And here on the left of this slide, you can see a number of different statistics here. One I think is really important to note is that 1 in 4 households have someone living with migraine. And it can cause an average loss of 3 work days, 5 days of daily living activities, and 2 days of social activities every 3 months. So clearly the data shows exactly what you all have responded with, is that migraine has a very big impact in the day-to-day. And looking to the right side of this slide, when it comes to the LGBTQI plus population in particular, we know that these patients actually have a higher disability as well as burden related to migraine. So gay, lesbian, or bisexual individuals are 58% more likely to experience migraine than heterosexual individuals. And there was a study quite a number of years ago looking at the prevalence of headache, severe headache specifically, and migraine. And bisexual women had the highest prevalence of migraine compared to lesbians, bisexual men, and gay men. And all of those patients actually had a higher percentage of migraine compared to heterosexual women and heterosexual men. So there's clearly a disparity in terms of migraine prevalence. So why is this? So when we think about why migraine may cause more disability in the LGBTQI plus community, we know that LGBTQI individuals have higher rates of, stigma and discrimination. I won't go into too much detail in case this may be triggering for some on this call. But there was a study that came out about 2 years ago, almost now, that showed that a history of trauma and or discrimination was associated with an increased likelihood and increased disability from migraine. This can also include trauma such as, adverse childhood experiences, assault, harassment, and so on. And LGBTQI plus individuals are 4 times more likely to be the victim of violence as well as these adverse childhood events. So we know that this can increase the risk of migraine. We suspect that this may be one of the major components of this disparity that we see. And also, LGBTQI plus individuals are more likely to experience, obviously, migraine frequency and disability, as well as stigma in care, but they're also less likely to receive timely consultations, appropriate diagnoses, and or acute and preventive medications or treatments. And we think that there are many barriers to access to care as, one of the main components of this. So unfortunately, I have had many patients tell me they've been discriminated in a healthcare setting prior to coming to our office, where they've seen providers. They're not able to access gender-affirming care. They're not able to physically get to their appointments. They may not have insurance, so therefore they don't have access to specialty care or primary care in general. So there are a number of different barriers to care that may prevent individuals from going to see a headache specialist, for example, and therefore getting the appropriate diagnoses and also potentially getting treatment earlier on, which may then lead to worsening headache over time, which then can continue to be chronic and obviously disabling.
Just a quick question, Dr. Pace. I think it's interesting that you have here the interactions between migraine medications and hormone replacement therapy. What happens in a situation like that?
It's a great question. So, unfortunately, not all providers are knowledgeable about drug-drug interactions with hormone therapy. So it may be possible that a provider may suggest a preventive medication for migraine that may affect the level of testosterone or estrogen that a person is receiving, which obviously may have negative effects as a result of that interaction, whether it's more side effects from the migraine preventive therapy, or if the estrogen or testosterone is affected, how that may affect the patient negatively from a physical perspective and a mental health perspective as well. So there are multiple layers of challenges that come up as a result of the interactions between migraine medications and hormone therapy. We'll actually talk about that in a couple of slides as well.
Thank you so much, Dr. Pace. That was a really good overview of the state of migraine in the LGBTQI community. Now, I want everyone that's on this webinar to take a moment and think about the barriers that you might face in your migraine care. These can be some of the issues that Dr. Pace had explored earlier. They could be challenges in getting your medication. They can be feeling misgendered or not seen in a practice. So if you want to just write, if you're comfortable, know that this is not necessarily confidential. Some of the barriers that you might have faced in your migraine care. And while people are thinking, I'll share that while I have a lot of privilege and access as a cis white man, understanding that it's the importance of having providers that understand and affirm identities and using our privilege when we have it to break down those barriers is critically important. So while that may not have been a barrier for me to receive care, I know for many in our community it is. Move up to the minute. So achieving the care that you deserve, that's something that we also really need to ponder, because we often don't feel like we deserve to feel better, or we don't realize that fine isn't fine. I'll turn it over to Dr. Pace to go over some survey highlights.
Sure. So Prime had set out a survey a number of weeks ago to kind of help inform this town hall, and these are just some of the results that they found. So you can see and you all are able to read through this on your own, but just to highlight the people who responded to these surveys range across various gender identities as well as sexual orientations. And interestingly, there was a large percentage of respondents who identified as cisgender men. But there is a good mix, and also ages were interestingly ranging from age 17 to 75. And the estimated headache days per month on average was around 10, but ranged anywhere from 1 day a month to 30 days a month. So one of the questions that was asked on the survey was, which of the following do you experience regularly as a consequence of migraine? So we talked a little bit about in the beginning how migraine can impact your day-to-day, and the majority of people who responded to this survey said that canceled or postponed social plans was a regular consequence of migraine. And I can speak to that personally as well. And I'm sure many of you also have unfortunately had to cancel plans because you did not feel well and were not able to get out of bed. Missed work days was the second. Less quality time with family or friends. Guilt about missing out on activities, I think, is something I hear very frequently from many of my patients. Joe, I don't know how you feel about any of these responses, or if you've experienced any of these before.
Yeah, I remember I serve on a couple of boards in my community, and the executive director of the board saw me have an attack. I posted a video, I think, on social media, and they said to me, I didn't realize how bad it was, and I thought you were just trying to get out of coming to a meeting. And I that really made me think about how many times people might not articulate that and how often we miss things that are important to us, and people might judge us for it when we really, really want to be there. So this aligns with my perspective as well.
I do think that's challenging because I imagine that people also may be hesitant to explain that the reason why they're missing a social activity or work, for example, is because they have a migraine, perhaps because they may not be taken seriously, or worry they may not be taken seriously because they're told it's just a headache, take a Tylenol, or you can power through, it's fine, the lights will be dim, kind of thing. So the next slide, talking a little bit about which factors prevent you from taking care of your migraine symptoms the most. So the top two answers were having enough money to afford things like food and housing, and having access to quality and affordable healthcare. So we talked about those two as common barriers to care for migraine especially, but also for many other kinds of medical care. And the biggest challenges faced in receiving migraine treatment is finding medication that works and finding the time or resources to follow lifestyle recommendations. I know that is very difficult. And, if you're not able to seek care from a headache specialist or someone who is comfortable managing migraine, it's very challenging to find the right medication that works, and also try to understand what's going on with migraine and how you're able to treat them appropriately.
I just want to ask a question. I think it's interesting that the majority of respondents are mostly satisfied with their current treatment, because on your last slide, but the biggest challenges they face is finding medications that work to manage symptoms now on this slide. So, just something I picked up. So wondering, I guess people are satisfied, but they're still maybe looking for newer treatments.
Yeah, so I think, from a headache perspective, many of my patients feel sometimes that it's, as Joe was mentioning, fine, where they feel okay enough that they can function, but maybe the headache or migraine symptoms are not completely gone. So they think, okay, maybe this is it. This is as much improvement as I can get. Whereas perhaps other people may say, oh, I can function, but it's still affecting my ability to think clearly at work, or I'm not completely present when I'm, with family or friends. Can I do more, or can we do more? How can I get, better relief from my symptoms? And perhaps also patients are thinking that the head pain is the thing that they need to have relief from, as opposed to the brain fog, the nausea, the light and sound sensitivity, some of the other non-pain symptoms that they perhaps have learned to deal with for a really long time and are just part of them, or part of their baseline level of functioning, when they don't actually have to deal with those symptoms on a day-to-day.
Yeah.
I want to point out, I'm sorry, Shirley. From my perspective as a patient, the finding the time to allow both treatment and lifestyle changes to work or not work. And I think we, in this Instagram culture, especially with lifestyle changes, we think if we start eating a good diet that is told to us, or start exercising, that automatically that will help. But sometimes it takes some time for those to be seen as effective or not. And I think a lot of us don't give ourselves the space to explore in that way.
I
I'm
also would,
sorry, Shirley.
oh, sorry, go ahead, Shirley.
No, go ahead. You comment first, and then I'll have a comment. Go ahead.
I just wanted to reiterate that I think when we think about lifestyle modifications, I think it's very easy to say, well, you didn't get enough sleep, therefore you got a migraine, or you're really stressed, you stressed yourself into a migraine. And what I try to explain to patients, and I think hopefully, when I teach students as well, is to explain that it's not your fault. You're not doing something that's causing the migraine to happen to you. Your brain, is vulnerable to attacks when certain things about your routine may be disrupted or a little bit off from what your baseline is. I really try to shy away from stress as a trigger so much as we think about stress biologically as a fight or flight response. So if cortisol, which is like your adrenaline, is rushing, that's a stimulatory type of hormone. And we know migraine is a hyperexcitable kind of process. So anything that's increasing that stimulation, of course, is going to increase your likelihood of migraine attacks. So when I try to explain as more of a biological concept and less of you're psyching yourself into a headache, which I think is sometimes how providers can explain it, I like to think hopefully that takes blame off of patients and have them, feel less like they're stressing themselves into a migraine and more of understanding like, well, my body is responding to outside stressors in this way biologically. And how can we kind of, monitor or modulate the biological response to this in some way so that there's not all this extra hyperstimulation of your brain that already is happening as part of the migraine process.
Yeah, thank you for saying that. And I just want to, you were talking about internalized stigma, also something that patients may not be familiar with that term. I know we're going to talk about stigma in a little while, but I think that, we need to do a better job of measuring stigma. But someone wrote in the chat, which I think, again, this is based around maybe institutional stigma we would call it. It says, as a transgender man, one of the barriers I have encountered has been the assumption that my hormone therapy is actually causing migraine. Instead of receiving treatment, I get told that I should stop or limit the hormones that I take, which is incredibly frustrating. Wow, there's a lot of stigma in there.
And I think, we as providers really need to do better in supporting our trans and non-binary patients who are on hormone therapy, because our headache management should support the hormone therapy continuation. It should not be competing for. Patients should not have to choose, do I continue my hormone therapy or do I manage my migraines? They should be able to do both. And they're not causative. The hormones do not cause migraine. There are many other reasons why we understand that migraine can happen in any individual, regardless of being on hormone therapy. So our job really is to support individuals who are on hormone therapy and manage their migraines if they happen to have attacks while they're on hormone therapy. But thank you very much for sharing that experience. And I'm sorry that that has been something that has happened in terms of you trying to receive care. Okay. So segueing into stigma.
Yeah, look, it's like we practiced this. So it's really important, as we're hearing come out of this conversation, to understand that you don't cause your migraine. It's a disease that you have. And as Dr. Pace and Shirley were explaining, there are things that could make an excitable brain more excitable and cause migraine attacks and other symptoms of migraine that we'll discuss. We often get told, and I've seen this in the comments, that it's just a headache. It's a complex whole body disease. I was explaining to Dr. Pace about an experience I had yesterday during an attack where it hurt to walk down my stairs because the vibration of the walking just like hurt me. And people might not understand that when you say migraine, that, getting out of bed to go make a cup of coffee can be a production. Stigma can cause delays in getting treatment. We don't think that it's serious enough to get treatment. Or in the case of the LGBTQ community were nervous, as the one person pointed out, that they might attribute it to hormones or something else that we're doing, and this affirming care that we need to live our whole or authentic selves will be taken away from us. And that's a really challenging thing to grapple. So what's more important to you, the affirmingness of your gender or treating your migraine disease? There's additional barriers in different institutions, personal and systemic meaning by society. We talked about some of the discrimination that we faced earlier, and the hate crimes and the propensity of violence towards us. All of that can impact our ability to get care. So thinking about all of these barriers and all this bad stuff that happens to us, we have a magic wand, and you can wave that magic wand. What would make it easier for you to talk about migraine if you were able to change the world tomorrow? And as you're thinking about that, as you're waving that magic wand, who would be there to give you support? You could type in the comments, and I know that there's been some issues with the comments. We were notified that Prime's looking into the attributing comments issue. So as folks think, I'll share my magic wand would be that when my provider, my doctor, wants to put me on a medication, I will be able to get it without any barriers or hoops. I wouldn't have to spend hours on the phone, wouldn't have to feel like I'm burdening his office because they have to do prior authorizations. And the relationship that I have with my provider would be sacred and upheld.
Yeah, I just want to comment on what you said, Joe, about prior auths, because I just came back from Headache on the Hill last week, and we were there trying to work with reducing the interference that we all receive when we have to go through step care therapy. And so that's when the Safe Step Act. That's right. Thanks, Becky, for putting that in there. And that's something that is a real barrier to getting the care that we need and deserve.
Totally agree. Probably 10 years ago, the Global Healthy Living Foundation coined a term, fail first hurts. So failing first hurts us. It hurts us economically because we're filling prescriptions that we probably won't use or need. And it hurts us physically and mentally because we have to try things that we probably know won't work, or providers probably know won't work, because an insurance bureaucrat feels that that's what we need to do to save their bottom line. So critically important legislation, the Safe Step Act, something that everyone should support.
And on the provider side, it is incredibly frustrating to have to try to argue with insurance companies to get approval for a medication that we think is most appropriate for a patient, and be told that, well, they didn't try 2 other medications that are inferior to that medication, therefore they have to try those first, and then maybe they will cover the medication that we are writing for in the first place. Or patients are denied coverage for medication they've been on for years because the formulary changed, and no rhyme or reason or no explanation whatsoever. But unfortunately, it has gotten worse over the last number of years. And I find many of my hours outside of seeing patients are spent arguing with insurance companies, writing letters of medical necessity, begging insurances to cover medications that we know work for patients, just so that they can have a chance to function and go back to work or school.
And we're seeing some great comments that folks are writing in the chat. Thank you, Becky and Maddie, for sharing the emotional impact and how we can make that better. So shared decision making, we kind of talked about this inadvertently, and we often do when we're talking about proper healthcare treatment and relationships. So shared decision making means that, in the way I understand it, is there's a power differential between physicians and patients. Doctors have degrees. Often we don't. as patients. But what we do have is our lived experience and understanding of our bodies and our disease. So shared decision making is bring those two things together to come up with the best treatment plan for the individual person at that individual time. And a lot of it has to do with understanding what matters to us as patients. Is it the reduction in headache frequency? Is it the ability to be a little bit more predictable and get on a treatment that might stabilize us more? Is it the way in which a treatment is administered? Do we prefer an oral treatment? Do we prefer an infusion that you go on a certain schedule? Do we prefer an injection that we'll give to ourselves? Do we prefer other types of treatments and therapeutic options? Do we want to try things outside of pharmacological approaches? These are all conversations that providers and patients have in a shared decision-making model. You understand what is important to you as a patient, and your provider, your doctor, comes up with a plan with you. Communication is respected in both ways. You respect the expertise of your provider, while they respect the expertise of your lived experience. Dr. Pace, I'll turn it to you.
Thank you. I just want to kind of highlight one comment in the chat. Kelsey wrote, I feel generally comfortable, but I worry about sounding needy if I've asked for things recently. Thank you for sharing that experience. I do notice that quite a bit with a number of my patients as well, that they feel kind of bad to bring up multiple other things during the visit, especially if they've discussed, multiple other issues, and we're, of course, always pressed for time. I do see that frequently, and I always try to encourage people to, bring lists with them to the visit, and I want to make sure that everything is covered in the visit that is important to the patient. But I can see how that would be it may be difficult to bring up multiple issues when you feel like you've already done that. You don't want to, as Joey, you even said, you don't want to bother your provider's office too frequently, because you don't want to seem needy. What is the top barrier you face in communicating your symptoms to your migraine care team? Most common was, I'm not sure which symptoms are important or relevant to share. So this kind of is in line with some of the comments. From a provider perspective, and similar kind of, as a migraine patient myself, I think the most important thing to share is something that's important to you. So if there are symptoms that you are worried about, or, things that you've noticed are affected by your migraine attacks, we want to know. Our job is to help you feel better and to get you back to doing what you want to do. So if migraine's affecting your ability to do that, we want to know how that is. Everyone experiences migraine differently. Everyone has different migraine symptoms. Some are more bothersome than others. But, if you're a painter and you have a hard time looking at your palette when you have a migraine, or if you are a cab driver and you get dizzy when you have migraine, you're not able to drive in the same way. Those are things we'd like to know. But anything that you are worried about or anything you think is important because it affects you, we want to know. So definitely, as I mentioned earlier, I often tell my patients, make a list of the things that you want to cover at our visit. Let me know what they are. Some people send them to me in advance, so I kind of have a lay of how the appointment's going to go, so I know what things are most bothersome to them. And I, let the patients kind of lead the interview and lead the visit. So that way I make sure that we cover everything that they're concerned about. And then I ask my questions afterwards. Sometimes I'll, interrupt in between to ask questions to clarify things. But, you as the person with migraine should be leading the visit in terms of discussing what your worries are, so that we can kind of address those and make sure that the treatment plans are in line with what your goals are.
Dr. Pace, I just want to hop in and add two comments. One, for me, it wasn't until I went to some education programs that talked about headache days that I understood that would help me get on better treatment. I didn't know to tell my doctor that I had a baseline headache, which was not really impacting me, so I wouldn't think about it. But that background, like buzzing noise that just was there that, was mildly annoying, but wasn't a full-blown attack. So when my primary care doctor would ask me, how many migraine attacks are you having? I would say 4 to 6. When I really looked at it, it was like 14 to 16. And that's a big difference. And that opens up different possibilities for treatment.
That is a
And that was
great point. That is a really great point. I think many people kind of get used to symptoms that they've had for a really long time and may not think to mention it or realize that maybe that's not how everybody feels every day.
And then one last thing, doctors are people, and I forget that often. But I see Becky writing about the doctor thinking that she might be medication seeking. If I was feeling comfortable enough and I felt like a doctor was feeling that about me, I would potentially ask, "Hey, listen, I know you want me to get better. This is how I think I can get better. I feel like you think I might be medication seeking. Is there a way that we can come together to get me to a place where I want to be?" And I've found that that type of tactic works with many doctors, not all of them. Some of them will be jerks, like people in real life. Not everyone will be nice, but sometimes it really works. And Sarah's comment about providers asking gender pronouns and understanding that it's a full process from the moment you step into an office. That check-in process sets the tone. So thank you for that comment.
Okay, so kind of to piggyback on how to prepare for a visit with your migraine care team, as I mentioned, I love data. I think many headache providers love data, but I think it also is helpful for patients to write things down before the visit. You never know if you're going to have a migraine attack during the visit. You may not be able to look at your phone or your screens, or write down things as eloquently as you may want to. So having, a headache diary where you're charting out your symptoms can be really helpful. Less is more overall, unless you're also into data and you really like charting a lot of different symptoms and you feel like that's important. I find that the best kind of diary is one you can keep. So however easy that is, whether you do it on paper or you do it on an app or you do it on your notes tab or something like that, you can do, rate it mild, moderate, severe. You can pick your most bothersome symptom and look at that one. Everyone's diary is different. So I try to, meet my patients halfway in terms of how they're charting out. But anything that you can do to keep that diary consistently is helpful. And also coming into the visit with questions, having your list of medications if you're a new patient. And you can also practice sharing your symptoms or your experience with, a trusted friend or family member beforehand. And, that hopefully, or you can bring that person to the visit with you. I find a lot of my patients bring a support person with them so that if they forget something, the support person can kind of chime in and say, "Oh, remember you were talking about this." And that seems to be also really helpful during the visit. So then during the visit, we've all kind of alluded to this. Speaking up is really important. Talk about your most important or troublesome issues first and talk about what you feel comfortable with. So I have many patients who say, I have this many headaches per month. I'm not really interested in a preventive therapy that's every day, or I'm not really interested in taking a pill every day or an injectable. I'm really afraid of needles. I don't really want to do injections. What other, preventive therapies are there? Talking about anything that concerns you and asking for clarification. So if a provider says, "I would like to, recommend this medication," and you don't understand why, or they're explaining side effects, you don't know what they mean, ask to clarify. And you can ask for additional resources, related to patient care or some of the medications or other treatments. And I love when patients ask questions, and I always encourage people to ask questions. So what should you expect over the short term, over the long term? How do you even know your migraine treatment is working? What should you look out for? What symptoms should you be monitoring? What side effects should you be expecting if you are to experience any? Some may not have any, some may have more. Talk about the lifestyle modifications that we talked about before. And then, of course, insurance, which we talked about as well. What does the insurance process look like if there is a prior auth that's required? How long would I expect that to take? What do we do if it's not approved? What's our backup option? So lots of questions that we can discuss at the visit that hopefully will allow you to be more informed and have expectations in terms of where we're going together.
So As you heard from Dr. Pace's perspective, there's a handy tool that you can use that you could download tonight that could help you think this through because sometimes it might be hard for us to remember everything. So there's a worksheet that you can fill out so you have it with you. So this is a deep question. Identity is a deep issue, and one that cuts across multiple different parts of who we are. It's our identity. So thinking about that, what is challenging with balancing your migraine care with your self-identity? And we started to tease some of this out in the chat with some of the comments around feeling seen in offices, feeling seen as needy, feeling seen as less than worthy, um, or less than empowered. So I shared a strategy inadvertently, uh, being upfront with your doctor and treating them like a person. So for those of you that have been managing migraine for a bit, what would you share with either your younger self that has migraine or someone that might be newer to this journey? And you can type it in the chat. We'll just pause for a second before we get into the treatment options because that'll be a lot of information if people want to share their strategies to help people. We'll give you another couple of seconds. Becky, know that you're not alone. Yeah, definitely. The more that we know that there are others like us, it's why I'm pretty upfront. And I shared earlier today that I had a rough day yesterday, and I feel like I'm not going to lose my job at the Global Healthy Living Foundation if I'm honest about migraine. So I have that extra privilege of not worrying. Some folks might feel like their performance will be judged, but many of us have the luxury of being able to say we had migraine and that it's bothering us and that it impacts our life and that you're not alone. So wanted to just go over, and I'm sure everyone on here has experienced almost all of these, if not all of them at some point, if you've lived with migraine. We often think of head pain as the primary issue with migraine, but as we said earlier, it's a full body disease. A lot of people can be fatigued and tired, and fatigue is much different than not having one good night's sleep. It's some people have explained it as trying to walk through jello or feeling like someone's holding you down when you're moving. Irritability is another symptom of migraine. Stomach issues can be symptoms of migraine, and then depression, anxiety, and other whole body diseases like cardiovascular disease can occur with migraine. So it's a very serious neurological condition. And we're getting a lot in the chat. Uh, trust your gut. Definitely, if you don't feel like if a provider is not supporting you, get out. There's a way to break up with your provider. It's a relationship. If you're in a bad relationship, it might feel like there's not a lot of choices and there might not be many, but there's always a choice and there's always something else to do and there's always a way out. I've struggled with sharing my identity and pronouns in the doctor's appointments. I've been seeing a headache specialist for years and still haven't shared that with her. I have top surgery coming up this year, and I know I need to discuss it with her, but I'm worried. Yeah, this is really, really challenging, and it's about being out in a certain way. It's something that we have to navigate, our safety, and also are we going to get the same care? Are people going to look at us differently? If I talk about my boyfriend or going on dates with men, is that provider going to then think that something else of me and not take me seriously? If you're bringing up your pronouns in this current climate where that could be seen as something that's so wild, which doesn't make sense to me. It doesn't impact people by sharing your pronoun. I don't know what the big uproar is, but there's a real reality that in many parts of this country, that just by saying, hi, I'm Joe, my pronouns are he, him, that could throw people into a tailspin and make them not hear anything else I say. So it's something that we really have to work on as a society. And unfortunately, it trickles down in all aspects of our life, including the healthcare that we receive. Sorry for my soapbox. Thank you, Maddie and Tessie, for your comments.
Yeah, thank you. That was really also eye-opening for me as a provider. I'm fortunate enough to practice in New York City, where pronouns are a very common way that we introduce ourselves in our office. So it's hard for me to imagine how it may be in other states where that's not information that's shared on a regular basis. So very briefly, we'll go through, just in the interest of time, the difference between episodic migraine and chronic migraine really has to do with the number of days of headache that one experiences. Less than 15 a month is considered episodic. Greater than 15 days a month is considered chronic migraine. And those with chronic migraine do have a higher disability and healthcare needs and costs. And the difference between acute and preventive treatment, acute treatment is really taken when you have an attack in that moment. And the idea is to reduce pain, other symptoms. Not everyone achieves relief with an acute medication. And the acute medication doesn't change how often the attacks happen. A preventive treatment is something that you would take whether or not you have a migraine attack in that moment. And the idea is to reduce the frequency of the attacks, or how many days in the week or a month that they happen, and can also reduce the severity of the attacks. And preventive treatment is often the way that we guide treatment for chronic migraine, especially, but also for episodic migraine if attacks are very severe and disabling. Okay, so to talk a little bit about acute medications, all individuals with migraine should be offered treatment acutely. The goals may vary depending upon the person, but the most common ones: get rid of the symptoms, either pain or other most bothersome symptoms, few or no side effects. This should be affordable, and minimal need to have to repeat the dose. The table on the right is a list of a number of the different acute medications that we typically use. Triptans and Gepants are the two most common that have the best evidence for migraine treatment. You can read about the adverse side effects there, but overall are pretty well tolerated. Just want to make sure we get through our slides in the interest of time. So when should you try a preventive migraine treatment? So you should think about prevention if your migraine attacks are very frequent, if your acute medications or treatments don't work, or you have to use them very frequently, if you have any side effects with acute treatments that you're not able to tolerate, your preference if you want to try a prevention medicine, or if you're, as I mentioned earlier, if your migraine attacks maybe aren't terribly frequent, but they're very severe enough that they're affecting your ability to work, to go to school, to engage in social activities. So what are your options for preventive migraine treatment? There are many of them. You can see there are some traditional oral therapies, meaning by mouth, that you can take. And those are the typical anti-blood pressure medicines, anti-seizure medications, antidepressants. There are a number of new classes of medications, excuse me, the CGRP targeted therapies. Those are injectable forms or pill forms. And there was a recent guideline position statement that came out from the American Headache Society not even 2 weeks ago, suggesting or saying that the CGRP targeted therapy should be considered first-line therapy for migraine. We all knew this clinically, but it was really nice to see the AHS come out with this guideline, because hopefully that will help with many of the barriers that we have been facing in terms of insurance coverage and cost for these new medications, because they are much more expensive and much more difficult to get from an insurance perspective than some of the traditional pill therapies that we've used in the past. And of course, onabotulinum toxin A, also known as Botox, is another great preventive treatment. So what should you expect with preventive treatment? It probably will take a little bit of time for the medication or the treatment to kick in. Oftentimes people will experience a reduction in severity and then frequency. Some people experience both. Some people experience one or the other. Just because some people have side effects from prevention does not mean that you will get them as well. Hopefully with preventive therapy, you should be using your acute medications less often, and they should also work better when you do use them. And hopefully also the cost of the migraine treatment should be reduced over time as well, because for people who are using the emergency room or urgent care or other kind of urgent visits, those should be less so, as a prevention works and starts to help reduce frequency and severity of attacks. So we touched a little bit about this earlier, but how does migraine and hormones, how are they related? So we know in cisgender women that estrogen fluctuation seems to trigger migraine. So for those who have a menstrual cycle, the peak of estrogen and then the drop in estrogen seems to be something that makes a person more vulnerable to migraine attacks. We have very little data, unfortunately, in transgender and non-binary individuals on estrogen or testosterone. But what we do know from the two studies that were out in the early 2000s is that estrogen seems to be very pro-inflammatory, pro-migraine, and transgender women on estrogen seem to have, you know, a high prevalence of migraine similar to cisgender women. Testosterone seems to be anti-pain or anti-inflammatory. And so transgender men with headache may have some pain relief on testosterone or less pain overall, not just headache, other kinds of pain as well. I don't think this is really black and white the way this data suggests. And at least in my experience caring for transgender and non-binary individuals, it almost is never that way. It's usually multiple factors that are affecting migraine frequency and severity. And so as we kind of talked about, I hesitate to say the hormones specifically are something that affects migraine. But biologically, based on the data that we have, it seems that estrogen may trigger aura, which is, you know, kind of many people see spots or zigzags in their vision before their headache comes or have tingling. They may lose their speech. That's kind of an example of an aura. We know estrogen and aura are closely tied to each other. Interestingly, CGRP, which is the molecule that's targeted by a number of the new medications, may be affected by estrogen as well. So that may play a role in the type of migraine treatment that you can receive that may be helpful. You know, some hormonal treatments like estrogen in particular may have a higher risk of stroke. Migraine with aura also can increase your risk of stroke. We don't have data on those who are on estrogen for hormone therapy and also have migraine with aura and what their stroke risk looks like, but that's a question I get asked all of the time. So to be determined. And triptans really shouldn't be used if people have coronary artery disease or have had a heart attack in the past. So those are things to think about. So forging the path to freedom from migraine. Turning over to Joe again.
So, what experiences helped you feel empowered about your care? And that's a interesting word, empowered. What makes you feel like you have the ability to impact your migraine care? And in what ways have you taken charge of your migraine management and overcome some of your challenges? So, in other words, how did you take everything that we've been talking about and apply it in different aspects of your life to get the best care possible? I need to type in the comments. We're gonna go on to the next slide. We'll definitely call out the comments if they come in, but just because we have a couple of minutes left.
So very quickly, kind of, you know, reviewing something that we've talked about quite a bit as topics that patients wish they had more time to discuss with their providers. You know, again, kind of reiterating what we've all discussed, talking about medication side effects and how can we best manage symptoms that you're experiencing, and which aspects of your care do you think your migraine team could most improve upon. The most common response was becoming more knowledgeable in LGBTQ plus specific migraine concerns and asking all patients about their gender identity, sexual orientation, preferred names, and preferred pronouns, which has been coming up on the chat quite a bit. And I agree, it needs to be more commonplace for providers to introduce themselves with their name, their pronouns, and expect patients to respond the same. And that goes from the minute you walk into the door to the minute you leave, with any support staff, people talking to you on the phone, as well as, you know, your provider who's sitting in front of you, the medical assistant, nursing, and so on. So take action. So how can you create a plan to improve and sustain migraine control? So again, we talked about migraine really is very individual. There's not one medication. There's not one way to manage migraine. I could take 5 patients who have the same age, same gender identity, same sexual orientation, and all of their treatments are completely different. So it's really important. Communication, I think, is the most important. We as providers don't know what you prefer unless you feel comfortable saying those things. We have an idea in our mind of what we think may be most beneficial for you, but that may not be in line with what you think you want to do or what you feel comfortable trying. So it's really important that there's clear communication on both sides, so that we as providers can understand what you are experiencing, because you are the person who is experiencing the migraines. I can imagine what you may be experiencing, but I don't know. I'm not in your shoes. So it's really helpful as providers for us to know exactly how migraine is affecting you and what your concerns are, so that we can, recommend based on our experience and our, knowledge, what we think might be helpful for you based on the symptoms that you're describing, and also what your preferences are. It's also really helpful to think about lifestyle changes, as well as things that you think may make you more vulnerable to attacks. Like Joe and I were talking about, the weather this weekend on the East Coast was really bad. So many of my patients were experiencing more migraine, and so on. And again, shared decision-making is really important.
So it's important that you find a provider that meets your needs. There aren't really that many great resources specific for migraine, but there are some for general health, and you could see that here. Another thing that I like to do is contact my local LGBTQ center. They probably have resources or know providers that can help. Here are some resources generally for the migraine community, and LGBT specific resources that you can find. So you see Miles for Migraine and Migraine Again, who hosted this. If you look at Talking Head Pain, we're 2 LGBTQ people that have a podcast about migraine. We unfortunately interview people outside of the LGBT community too, but we try to highlight underserved people as much as possible. And I hope you appreciate my humor there. Any questions?
I think we have a couple of good comments here in the chat. Let's go back a little bit. Maddie said, I think something that empowered Maddie was breaking up with their neurologist who didn't seem to care, taking their partner to appointments, and being up to trying anything. Thank you for sharing your experience. Then Becky responded, finding a care team that listens when I speak about my direct needs during the appointment and continuing to be available via chat or email when I need them. I think that's really helpful also, is knowing that you can still talk to your provider outside of the visit if something does come up more urgent. Marilyn said, realizing the vital importance of lifestyle factors. Instead of figuring out I could power through, even though many good neurologists don't tackle migraine aggressively. Thank you for that. That's really interesting that maybe some neurologists are not as aggressive as you may like in terms of managing the symptoms. I think we're running out of time, unfortunately.
Yeah, we're running out of time. So in closing, I just want to thank everyone for participating in this program.